Um, Thank you, everyone. I'm a generalist. So the world I live in is where we put things together. So people who have uh, chronic and complex disease, the multiple diseases, and we manage patients together. And most of this chronic disease today, they're slightly different from the diseases that we used to face in the past, which is chronic disease doesn't get cured in hospital. It's how you manage yourself in the community that matters. So no one comes from the hospital, goes back and says, I'm cured of diabetes or, hypertension. And so that's where the biggest problem is. And this is our problem. And we have only 1 in 3 people get the care that they need to get. It's not because doctors don't want to provide the care, or it's just a very complex system that involves a lot of people. And this is what we should be doing. So with chronic and complex disease, because they're not managed well in the hospital, in the community, people start coming back to the hospitals. There's a lot of pressure on the hospitals. And if you don't prevent the condition or provide better treatment in the community, then it creates a huge challenge to the patients because it results in affordable healthcare costs. Uh, and the hospital systems because they're just crowded and if we struggle to meet the needs. Now, I just thought I'll tell you one story of a lady by the name of Mary that highlights the complexity of it. So Mary is a 65-year-old lady. What happens is she is a known asthmatic. She gets admitted into a hospital. So when you get admitted into a hospital with asthma, they give you steroids to settle your asthma down. When you're 65, it's quite likely that you have underlying diabetes, and in that instance, her diabetes got unmasked while she got the steroids. So, so what they did was they got the sugar doctors to come and see her, and they started on some sugar treatment, insulin, and that settled her sugars down. And with her steroids, her asthma got better, and they did even better. What they said was, well, Mary, you're doing well. We taught you how to, use your insulin, and we'll send you home. And what we'll do is we'll send 2 people to come and see you at home. We'll send a respiratory nurse to come and see you to make sure your asthma is working okay, is getting better, and the diabetic nurse to come and see you to make sure your sugars are traveling okay. So Mary goes back home, and day one, the diabetic nurse comes, looks at her technique, everything, looks at the sugars. She's great, just keep going with insulin. The respiratory nurse comes and she says, well, you know what, your asthma is actually doing really well. So let's reduce your steroids. Now, if you remember, the reason the sugars went up was because the steroids were started, right? So if you reduced your steroids, you should reduce your insulin. But unfortunately, that didn't happen because the diabetic nurse had already come and gone away. So after steroids were reduced, Mary was on the same dose of insulin. And that dropped her sugar. She went right back to hospital. It was no one's fault. It's just the complexity of the system, is all I'm saying. So what happened here is what we call clinical practice variation, right? Something that did not have to happen, but happened and didn't help no one. Why did that occur? The system's so complex that clinicians find it hard, to do the right thing, the communication and things. What does that do? If clinicians are not able to do their job, we really can't engage our consumers, if that makes sense. And affordable healthcare admission, and we call that low value healthcare. So in that particular instance, just to add some numbers up, 2 nurses, $500,000 right there, an affordable hospital admission. It just it means it is problematic. So this is what it means. Sorry, my apologies for that. So this is what it means to the system at large. 1 in 3 potentially preventable admissions occur because we are not able to provide care. So what is the problem there? The problem was complexity of care. You see, there's so many people involved, and it was just complex. And the challenge there, in some instances, is that there's lack of standardization on how we provide care. And now that the thing happened, you see, there's no learning mechanism that learns out of that and says, all right, next time we won't do this. Some people have learned and it just disappears in the system. So again, that results in the same problem: clinician inefficiency, consumer disengagement, and low value healthcare. Now, the good thing is we know how to solve this. right? To give you an example, within hospital systems, within hospitals, not in the community, there's something called the Clinical Emergency Response System. So what happens there is when people become unwell, there are very set triggers that trigger certain care pathways. And everyone knows what their roles and responsibilities are, and it works very seamlessly. It's so good that after the clinical emergency response system was implemented, cardiac arrests in the ward pretty much disappeared. They People who had cardiac arrest, they had them in ICU, not in the ward. Amazing stuff. Similarly, we have other care pathways like antibiotic administration and sepsis. It went from 50 to 60% to 90% within 1 hour. So the point I'm making is we can have processes. And the processes improve care as long as you can coordinate seamlessly, and that's where I thought AI could help. So that's our problem: complexity of care. And I thought the AI solution seemed to have kind of align with our problems. And I thought it can provide better value care. One problem that I think AI can help is a really simple problem. This one. 1 in 2 of our patients we send home to the nursing home, get inappropriate medications. We have about 230,000 admissions in a year because of inappropriate medications. 2,000 deaths. That's more than the national road toll. And $1 billion. So AI can help there.
Thank you very much.